Okay, we're going to start Chapter 19, Plastic and Reconstructive Surgery, starting on page 723, but we'll start the actual lecture on page 724. This one is a lengthy chapter, but it still is not as lengthy as ortho, so this will be the second longest chapter of the unit, and then the third being the oral maxillofacial. Okay, so starting on page 721, under the introduction, plastic or cosmetic and reconstructive surgery refers to procedures whose primary goal is the restoration of appearance or function to a particular body structure. I know it's easy to think that Dr. 90210 and all of the other plastic surgery shows that we see on TLC or on TV, that's what depicts what plastic surgery is all about. Plastic surgery really encompasses way more than just vanity and cosmetic procedures. It actually helps cancer patients get their body image back. It helps with function and form. Um, so there is more than just breast implants and eye lifts. Okay, so looking at the equipment on 724, there in the red, a dermatome is an instrument used to cut thin slices of skin called a split thickness skin grafting for grafting. And we're going to talk more about split thickness or STSG versus full thickness FTSG here in a little bit. Just make sure that you know what a dermatome is. Okay, so on 725, you can see the typical plastic instrumentation set and a rhinoplasty instrument set. Rhinoplasty, remembering from medical terminology, that's the surgical reshaping of the nose. And then we'll also be talking about augmentation. And augmentation is a process of increasing, refers to size, quantity, degree, or severity. Okay. All right. So looking on 726, it's a continuation of that table for the rhinoplasty set, but right above in the second column where it says other types of dermatomes, that little paragraph before, make sure that you know that first sentence. In addition to the dermatome, the surgeon may desire lubricant such as sterile mineral oil for the patient's skin. 100% of the time I've seen dermatomes used, it's always being accompanied with the mineral oil. And you'll see why here in a little bit when we talk about these different types of dermatomes. Um, but you need a nice slick surface. So the skin graft that you're shaving off that patient doesn't get bunched or balled up in the dermatome. You want it nice and lubricated. So moving on to the other types of dermatomes, you can see on this page, on this slide also, there's the Ferris-Smith, the Watson, and the Weck. But the one that we normally use is called the Paget, which is that second one, where it says the Paget and Reese drum type dermatomes. Those are very, very common. On 727, that first paragraph in that first column, a mesh graft device is often used in conjunction with a split thickness skin graft to expand the size of the skin that has been procured. So you can see that at the bottom there's that mesh grafting device, and what that does is you put your graft, your skin graft, on a meshing, like a piece of plastic, it's called a carrier, and then you crank it through and it produces all these little holes to let it expand. Okay, so this is the skin graft procedures. This is where a lot of the information is going to be coming from. As you can see, this says slide 1 of 8. So there is a lot of information that you need to know here. So first off, on 727, under skin grafts may be autografts, which is from oneself, or may come from another source. These options include allografts, which is obtained from the same species, such as from another person or a cadaver, and heterografts or xenografts. And a xenograft is a graft obtained from a dissimilar species, such as a pig or calf or even coral. And then a little farther down in the red, skin grafts fall into two categories: full thickness skin grafts, which is FTSG, or split thickness skin graft, which is STSG. And a split thickness skin graft is a graft that involves the epidermis and approximately half the dermis when used with a large surface area that needs to be covered. So at the bottom, this goes into a little bit more detail. It says, as the name suggests, an FTSG is composed of the epidermis and all of the dermis. So because of the depth of this type of graft, its use is restricted to covering relatively small defects, such as those created when excising lesions of the skin like squamous cell or basal cell carcinoma. And then on the next page, the STSG involves removing the epidermis and approximately half of the dermis for relocation to another part of the body. This type of graft is used when a relatively large surface area needs to be covered, such as in case of a burn. Okay, so let me make this a little bit simpler. A full thickness skin graft is usually taken by a knife. You cut into the epidermis and all of the dermis with a 15 blade, sometimes a 10 blade. You're taking a chunk out of a large amount of layers of skin, the epidermis and dermis. Whereas a split thickness skin graft, you're just going to shave with a dermatome that first couple layers, the epidermis and about half the dermis, because it's thinner, so it'll stretch more, and that's what you put through that mesh grafter, the split thickness. You can stretch it to cover large amounts, whereas a full thickness is going to be thicker. It would be like it's the difference, like a full thickness would be like, oh, I don't know, modeling clay that's harder, thicker, as opposed to a split thickness, which is like Play-Doh. It's more pliable, you can stretch it, you can make cool stuff with it. So that's what the difference is if I could do it like in those generalized terms. Okay. Okay, so continuing down past the bullets, the donor site when FTSG is performed does not heal by itself because no dermis is remaining. The donor site must be sutured for primary healing to take place. So again, we took that knife, we made a big chunk in this person, and so now we're going to have to stitch that together. Next paragraph at the bottom, as the outer covering of the body, the skin or cutaneous membrane has several major responsibilities. These include protection from external forces such as ultraviolet rays, first line of defense against disease and infection, preservation of fluid balance, vital in regulating body temperature, excretion of waste via sweat, sensory input through receptors for temperature, pain, touch, and pressure, and then synthesis of vitamin D. And synthesis is the formation of a new entity out of the previous existing ones. So we are synthesizing vitamin D. Okay, that last part could have been placed on the previous slide, but continuing. Okay, so in red, the integumentary system, and integumentary is just pertaining to or composed of skin. So the skin system consists of two main layers. The outer layer is called the epidermis and the inner is called the dermis. And you can see this on 729 in that figure 19.3, the structure of the skin. See how little, just this very flat, very small area of the epidermis, and then there's the dermis, and that contains sweat glands, capillary systems, all of the stratums. So that's what I'm saying. You have to suture this because look at all of the components of the dermis that's included in there: nerves, collagen fibers, arteries, veins, etc. Okay, but this is the epidermis layers from inner to outer up on the screen here or in the book. The stratum basale, spinosum, granulosum, lucidum, and the corneum. I'm not asking you to memorize these, but just be familiar with some of these terms. Okay, so down at the bottom in the second column, it says sebaceous glands are the oil-producing glands. The oil that is produced is called sebum, and sebum is oily substance produced by the sebaceous glands that reaches the skin through ducts that enter the hair follicle. It aids with fluid regulation and acts to keep the skin and hair soft and pliable. So sebum, it reaches the skin surface through the ducts. Okay, what I just read. Sebaceous gland activity is stimulated by sex hormones, which explains the lack of sebum in children, the dramatic increase in production at puberty, and the gradual decrease that occurs during the aging process. I mean, that makes sense. The sudoriferous glands are the sweat glands. Sudoriferous. There we go. Sudoriferous glands are the sweat glands. Okay, and then the last sentence on 729, the few locations that have no sweat glands are portions of the external genitalia, nipples, and lips. So that's why we have to constantly like lick our lips or lubricate these areas because there are no sweat or sebum glands. Okay, so on 730 at the top, burns are a major cause for performing an FTSG or STSG. So let's talk about the different types of burns. You can see them on the screen here, but the third paragraph down, first degree burns affects just the epidermis. They are characterized by erythema, which is the redness of the skin, but do not blister. So healing takes place in about a week and no scar tissue formation is expected. So a first degree burn usually is like your run-of-the-mill sunburn. Now sunburns can move into second degree burns depending on if you've fallen asleep at the beach or at the pool or just outside, but typically it's that rosy pink first degree burn. They can be pretty tender, pretty painful. Second degree burns are those that blister and are extremely painful. Second degree burns affect the dermis to varying degrees. Superficial second degree burns generally heal within 2 weeks and do not leave a scar. Third degree burns completely penetrate the full thickness of the skin and often affect the underlying structures. Permanent tissue damage occurs. So these are very painful. Further down, third degree burns appear charred and pearly white. They are referred to as S-scars. So S-scars are charred and pearly white skin that results from the third degree burns, those kind of scars. And then we have the fourth degree burns. Those are referred to as char burns. Fourth degree burns often damage blood vessels, nerves, muscles, and tendons and can even affect bone density. So these are the people that really have no more pain. They're not very painful because you have literally burned the nerve, that you've singed everything. Okay. These are the people that are also in the burn unit. Third degree burns also, but fourth degree, they're in the burn unit. You're having to take off all of the dead, charred skin. And there's a lot of bleeding. This is where nutrition comes into play because without nutrition, proper nutrition, then the body cannot heal itself or regulate temperature because they are constantly bleeding and producing fluid to insulate the body. And so these are very high risk patients. They're on IV nutrition. Okay. Continuing on, the severity of the patient's condition is also assessed according to the abbreviated Burns Severity Index, or ABSI. And the ABSI, it's a scale used to assess the severity of a burn patient's condition based on the patient's age and gender, presence of inhalation injury, depth of burn according to degree, and the percentage of the total body surface that has been burned. Okay. All right, so on the next page, that's 731, that table 19-3, the rule of nines, and you have the figure up at the top. Make sure that you know the rule of nines. So the head and neck is composed of 9% of skin, or 9% of the body area, body surface. Anterior and posterior trunk, that's 18% each on each side. Okay, upper extremity 9%, lower extremity 18%, and then the perineum is 1%. Okay, all right, so that takes us to our first procedure. All right, so our first procedure on 731, the full thickness and split thickness skin graft. So under the equipment, there you see there's that powered dermatome, and then the powered dermatome blades. And you'll have the same blade, but on the dermatome, there will be different guards for the blade, and the guards will represent how thick or how wide the tissue that you're going to be shaving off will be. You'll need a mesh graft device, a derma carrier, which is that piece of plastic I was telling you about that we put the skin graft on, then we crank it through the mesh graft device. And then you can see in the third column there's that mineral oil. Okay. On the pre-op preparation, that third bullet, which is part of the second column at the bottom, normally the donor site is prepped first and is considered to be clean. The recipient site, if it is an open wound or potentially contains cancer cells, is prepped last and is considered to be dirty. So a good place to take skin graft is on someone's thigh. So if we're taking a skin graft from a thigh and putting it on an arm, if like it's an open wound or whatever, you're going to prep the thigh first. Take that skin graft, prep the arm because that's dirty, that's glass, and we're going to apply that skin graft that we shaved from the thigh to the patient's arm. All right, so this takes us to a scar revision on 734. So under the anatomy, the third bullet, the goal of the procedure, which says Z-plasty scar revision, is to reduce the scar, realign the wound edges, and perform a closure which will have an improved cosmetic appearance once healed. So these are people with either disfiguring scars, or it's a scar that's providing or creating constricture where they cannot move very well because of the scar tissue, or it's just a really bad looking scar, and for body image purposes, they want it revised. So under the practical consideration, first bullet halfway down, the Z-plasty is the most frequently used technique. This is very common, especially on hands. Z-plasty allows the surgeon to make the Z-shaped incision in the same direction of the natural skin line, thus promoting healing and making the scar less noticeable. Okay, so you can see on 735, that figure 19.5, it's in the literal Z or an N, but it looks like a Z. And so it goes along with the folds of the skin. You can be more mobile. Whereas like if you're on a palm, let's say you're on the palm and you make a straight incision from the third metacarpal down to the wrist. If you make a fist, that incision is going to split wide open, even if it has stitches. But if you go in a Z pattern and follow those creases, when they make a fist, it's not going to split open. So you can see how this is very useful, the Z-plasty. All right, so that takes us to 736, the head and face procedures. And that first one is blepharoplasty. Okay. All right, so going back to medical terminology, on 737 under the practical considerations, the word blepharoplasty means surgical repair of the eyelid. Blepharo is eyelid, plasty is repair. The procedure is performed to remove excess skin or fat deposits of either the upper or lower eyelids and is usually a bilateral procedure. Sometimes these are for cosmetic reasons, but you can see at the bottom that A, like right above A, that's how normally a patient will present. So these are people with drooping eyelids, and sometimes it is inhibiting their ability to see. Their vision is impaired because they have such excess skin above their eyes that they can't drive. So they have to have an eye lift, this blepharoplasty. Okay, so under the surgical procedure number 2, you're going to use the 15 blade and an elliptical incision. So elliptical is that curved or crescent shape. That kind of incision is made along the ciliary margin following the natural curve of the eyelid. And you can see all this at the bottom in that 19:6 figure. Okay, next on 738 is the endoscopic brow lift, and you can see what that looks like on 739 at the bottom. But under the anatomy, that last bullet, brow lift is performed to reduce or eliminate the permanent horizontal and vertical wrinkles that occur on the forehead primarily due to aging. So this is pretty much a vanity, a cosmetic procedure for wrinkles, but you can see there's such small incisions along the natural creases of the forehead that it lifts and tightens. They go in and they pull up to give that look when Botox is just not working that well. Okay, on 741, the malar implants. So under the anatomy, the zygomatic bones, also called the malar bones, form the prominences of the cheeks and form the lateral walls and floors of the orbits. And then that last bullet, the submalar augmentation is performed in patients who have a deficient bone structure or severe atrophy of overlying soft tissue. The deficiency can also be due to trauma or facial surgical procedures such as cancer of the mandible. Okay, so these are people that those cheekbones, they're like really, really prominent. They're almost like jagged or very sharp looking. Um, and so they just look very, very bony, and they need something to soften the face, make it look a little bit rounder. And so we go in and put some implants in there to kind of puff up the cheeks, make them look not as severe, those cheekbones. Okay, on 743, the mentoplasty. The mandibular symphysis, better known as the chin, make sure you know another name for the chin, is the region inferior to the labiomental fold, the groove that separates the lower lip from the chin. And then that second bullet in the second column, mentoplasty is performed for purely cosmetic reasons, correcting micrognathia, which is a condition characterized by the underdevelopment of the jaw, in particular the mandible, or restoring post-traumatic facial disfigurement. And then the last one, the chin to nose relationship is an important consideration when evaluating the patient and discussing options. A small chin has the effect of making the nose look larger. Additionally, chin implantation will have an effect on the jawline and contour. Okay. Next on 744, the otoplasty. So the pinna, which is the external ear, is a framework of cartilage that is covered by a thin layer of skin that consists of the auricle and external auditory meatus. Okay, so if we're doing any kind of plastic surgery, it's going to be on the external part of the ear, which is that pinna. On 745, still under the anatomy, those last two sub-bullets, these are the deformities or defects that are corrected. The first one is microtia, which is the congenital absence or part or all of the ear. And then prominent ears is a term used to describe pinna that abnormally protrude from the sides of the head, most often due to an inadequate folding or absence of the antihelix. So sometimes back in the day, parents used to pin their kids' ears back, like with clothespins to their hair or other techniques if you have those big ears that stick out. Which I think I have, but I've been told otherwise. But this is kind of common. But if it's truly an absence or or any kind of weird folding on that back part of the pinna, we can do surgery to pull those in so they don't have such protrusions of ears. All right, the practical consideration for this on 746. The goal of otoplasty is to anatomically position the ears or reconstruct the ears so that they appear naturally proportionate and contoured with little to no evidence of surgery having been performed. When performing otoplasty for prominent ear, the goal of the procedure is to create an antihelical fold that brings the external ear back against the side of the head in a normal anatomical position. The ideal time to perform surgery is between ages 4 and 10, but preferably before the child starts school. So you want them to have that ability to heal, but also, man, kids are mean. And so before any social or body disfigurement images start, you want to have this corrected before they get into that social aspect of school where bullying can occur because of the way that they look. All right, so that takes us to on 748, the rhinoplasty, the external technique. So rhinoplasty is reshaping of the nose. It is considered a plastic surgery procedure because no functional changes are made to the interior nasal passageways. However, it may be performed in conjunction with other nasal procedures to repair the nose in the post-trauma patient. Okay, under practical considerations on the next page, often mentoplasty and rhinoplasty are performed together to improve the patient's overall appearance. And then the next column, third bullet, rhinoplasty is considered a clean, not sterile procedure. Okay, a lot of times you can do these with like a close reduction. Okay, that's first bullet in the third column where it's talking about the nasal speculum. Look at the 1, 2, 3, the fourth sub-bullet. So we can use cocaine, the crystallized form, and or oxymetazoline. Oxymetazoline for bleeding purposes. Okay. And then at the bottom, the surgeon will inject the local anesthetic into the nose and turbinates, and then will pack the nose with the cottonoids with cocaine. All right. So that will, oh, and by the way, if you do have cocaine on your field, first you and your nurse have to verify all that, but then when you go to discard the remainder, you have to be watched while you inject, like put the rest of it, you mix it with saline and you pour it over your sharps in the big sharps container. So no one can get that, that drug out. Like you can't leave it in a syringe or leave it in a cup. You have to pour it so it diffuses out over everything. And you have to be watched. All right, on 751, the rhytidectomy, commonly called a facelift. The procedure is purely cosmetic to remove excessive facial skin folds and subcutaneous tissue to eliminate wrinkles and fatty deposits. So under the practical considerations, that second bullet, facial nerve must be avoided when placing and holding retractors. And you can see on the next page where the incision is going to be. It's going to be mainly on the back side. We never want to make an incision on the face. Everything's going to be either up at the top by the brow where the hairline meets the brow, or behind the ears, sometimes maybe under the chin. All right, next on 753 is the cheloplasty or cleft lip repair. So the function of the palate is to separate the nose from the mouth, which is important in swallowing and speech. The anterior portion of the palate is the hard palate that consists of the palatine processes of each maxilla and the palatine bones. The posterior portion is a soft palate and is composed of muscle, fat, and mucous membrane. So you can feel this with your tongue, like towards your teeth, there's that hard palate. And then if you keep going back kind of towards your uvula with your tongue, you feel it convert to the soft palate. Okay. In the second column at the top, the fetal development occurs during the first trimester of intrauterine life. So it's talking about the nose and the mouth. So during the first trimester, the nose and mouth are developed. So a cleft in that last column, cleft, that means cleave, crack, or fissure. A cleft is a split or a gap between two structures that are normally joined. Chyloschisis, which is cleft or hair lip, and palatoschisis, which that's cleft palate, are two congenital deformities that can occur individually or are often seen in conjunction with one another. Okay, so chelo, that's the combining form, that means lip. And then schisis or schisis, that's combining form pertaining to lip, to split or cleft. Okay, so you can see this on the next page. So up at the top, there's the development of the face, but you can see when babies are born, they have that big fissure between the nose and the mouth. Sucking is very difficult. So these are babies that are usually undernourished because they cannot suck to get their nutrition. Or they just have an open, soft palate, and so now they're having trouble breathing and eating at the same time. So this is usually performed when they're still in an infant stage. So on 755, under the practical considerations, the optimal age to perform the surgery is not well established, but it is usually performed between 3 and 18 months of age. So very, very young. These are done at children's hospitals. Okay, that last column, second to last bullet, the temperature in the OR should be increased prior to bringing the patient into the room because they're so small. You want to have the room nice and warm. This is considered a clean rather than a sterile procedure because the aerodigestive tract is entered. So you're constantly going into where the carbon dioxide is coming out. It's dirty, it's not sterile. So, and again, you're going through the mouth, which can never properly be sterilized. It can only be clean because of all of the germs that are always in there. So this is just a clean case. Okay, so under the surgical procedure on 756, number 4, the letter A, that second line, I would underline Cupid's bow. And what that's talking about is on the upper lip, right under the nasal septum, where it dips. So you have your two humps on your lip and then the dip in between. That's called the Cupid's bow. And you can see that again on letter C on that second line, Cupid's bow. So make sure that you know that's where we're kind of working at, is right around that Cupid's bow area. On number 5A, you're going to be closing with an absorbable suture. Make sure that you have that absorbable. So A, B, and C, I just have them all underlined. Absorbable sutures, absorbable sutures, absorbable sutures. But you need to write something next to those. These are not only absorbable, they are fine absorbable sutures. So 6-0, 7-0, sometimes 8-0, depending on how small of a child you have. Fine absorbable sutures are used on these. So under that procedural consideration, again, due to the small size. So these are going to be, sometimes the needles are so small that you can put 2 in each square on your needle box in the foam. So you can count 2, 4, 6, 8. But kind of like the heart room, so they're going to be very small, very fine sutures. But you can see what the baby looks like on 757 before and after. And so this child will probably still have a little speech impediment, but not as bad as if they left it unrepaired, as in the A picture. Okay, they'll be able to talk, breathe, whistle, they can, but they may still have a little bit of impairment with speech. Okay, going on to the last one on 758, the cleft palate repair, the VY palatoplasty technique. What I really want you to take away from this one, on the surgical procedure, number 1, you're going to be using the Dingman mouth gag. Okay, and that's what you're using when you're doing a TNA in ENT to open up the mouth that you attach to the Mayo stand. That's what that's called, the Dingman mouth gag. It opens it up, and it's just a mouth retractor. Okay, so on 759, we're getting out of the head and facial procedures. Now we're going into hand procedures. A lot of plastic surgeons will have a fellowship or specialize, quote unquote, specialize in hand procedures. Dr. James Kelly, locally, he's one of them. He works on a lot of hands at RVO, but he does all of his plastics in his office. Okay, so under hand procedures, make sure that you know the anatomical positions. So there's volar surface, which is the palm of the hand, dorsal surface or dorsum, which is the back of the hand, radial on the next page refers to the thumb side of the hand, and then ulnar, which is the medial side of the hand or your pinky side, okay, the fifth digit. So in the second column, that first complete paragraph, the head of each metacarpal articulates with one of the phalanges. These joints are considered diarthroses, and we learned about diarthroses in the orthopedic chapter, which is those freely movable joints. And the synovial hinge type joints called metacarpophalangeal joints or MPJs. Okay, so this is a synovial hinge type joint consisting of a metacarpal that articulates with a phalange and is commonly referred to as a knuckle. So your MPJs are also known as your knuckles. Okay. On 761, let's see, I'm trying, yes. On 761, in this, you can see the innervation of the hand, and you can see all those bones on the previous page. But in the second column, excuse me, that second paragraph, it says dorsally there are 6 compartments, and so we're talking about for your ligaments. And then at the bottom of that paragraph, the dorsal carpal ligament collectively covers the compartments. So the dorsal carpal ligament. So there are 2 ligaments, the dorsal intercarpal and the dorsal radiocarpal. And so the dorsal intercarpal extends transversely across the dorsal surfaces of the carpal bones, and the dorsal radiocarpal is attached to the lower end of the radius and proximally attaches to the scaphoid, lunate, and triquetral carpal bones. Okay. All right, the tendons of the fingers and thumbs are contained in a protective covering called a tendon sheath. Okay, and you can see this on the next page, the muscles and the hands and all those sheaths and the tendons. Okay, and then on 763, the compartments of the hands. So if we do if they have compartment syndrome, if we have to do a CMC, which is a metacarpal compartment release, usually on the thumb side, this is what we're talking about all around here. So our first procedure on 765 is a toe to hand transfer. So on the anatomy, toe-to-hand transfer is performed due to trauma to the hand in which the patient's thumb was traumatically amputated or injured beyond use. Now, for pinching and for anything that you have to do with your hands, you have to have your thumb. It's your opposing phalange. And so if you get this amputated, we need to replace it for you to have good quality of life. And so we can transfer a toe that you really don't need for walking besides your big toe. Now you need your big toe for walking, but other than that, you can take a toe and transpose it onto the thumb area and use that as a thumb. Okay. All right. On 768 at the top, it's talking about preservation of a digit. So if you do get something severed, this is what you do. So, you want to put it in ice, preferably clean ice and clean water. If you lose a tooth, you want to put it in milk for the calcium. But when we're going to go to replant a nice clean digit that's been amputated, in the second column up at the top, replantation begins with bone-to-bone attachment. So we're going to align the two bones, the one from the severed finger onto the hand, and we're going to put a K-wire through there. So there's your bone-to-bone attachment. You're going to take some x-rays and then you're going to put a plate and screws. So now that bone is there, so now you can work on all the other structures, the nerve attachment, the circulation, and then the fat, and then the musculature, and then the skin. Okay. All right. So continuing on that talk, so the subtotal palmar fasciectomy for Dupuytren's contracture at the bottom, you can see what a Dupuytren's is on 769. So these are the people whose fourth and fifth digit are always contracted. It feels weird to shake their hand because their fingers are in your palm now. So that first bullet under that picture, all of these primary signs, which is there's signs over on the previous page, are caused by contraction of the palmar fascia. And so we're going to just go and relieve all that. We're going to cut those constrictions out. There is a heredity anomaly. They say that if you have, or if someone has a lot of Irish in their background, Irish, or I think it's Irish and or Scottish, that your chances of getting a Dupuytren's is higher. Not sure why. Okay. But this is another way you can see at the bottom of 770. You do Z-plasties all up and down the fingers, so you can bend those digits. Okay, on 771, the centralization of radial dysplasia. So that first, or actually the second bullet, radial, so again, radial hypoplasia or radial dysplasia or hypoplasia is the congenital defect commonly referred to as club hand, and is often seen in conjunction with deformities of the thumb, ranging from hypoplasia to complete absence of the radius. Okay, so radial hypoplasia is a congenital condition caused by the failure of the radius and adjacent soft tissue to develop, causing the hand to be medially deranged, typically associated with deformities of the thumb, also referred to as radial dysplasia. Okay. So you can see what's going on 772, the radial dysplasia. So on the left at the top, there's your normal hand. Type 1, you can see how the thumb is kind of like, it's just not as, I don't know, it's just not as prominent. And then in type 2, the hand is all the way over. And then type 3 and 4, I mean, there's just a severe deformity where they are just turning inward. And so we're just going to go and release, do a little bit of bone remodeling, and then we're going to have to pin. And you can see in B at the bottom where you put a pin through these bones to correct that with that K-wire, that Kirschner wire. So on 773, under the equipment, make sure that you know you need a wire driver because you're going to be using your K-wire set, your Kirschner wire sets. Under the practical considerations, procedure is performed when the patient is approximately 1 year of age. So we do a lot of these on babies, a lot of plastic surgeries on babies. Okay, so we're talking about the procedure on 774, number 9, a Kirschner wire or K-wire with a wire driver. Make sure that you put with a wire driver, okay, because you can't just stick in a K-wire with your hands. You need the wire driver. It's inserted through the carpus and third metacarpal into the ulnar shaft to reduce the wrist to hold it in position. Okay, and that's what I was trying to have you look at on that letter B in that figure 1925. Okay. All right, 775, release of syndactyly. So syndactyly, or webbed digits, it's a congenital abnormality that occurs when the digits of the hand or feet fail to separate. Okay, so these are, you can see in A, B, C, and D, they are sometimes fused together. either the bones are fused together or the skin, the dermis is fused together. So we have to go and release to create all 5 digits. Okay, you can see that procedure on 776, what that looks like. But that will take us to 777, the ablation of radial thumb and collateral ligament. So under the anatomy, the second bullet, duplication of the digits is referred to as polydactyly, and then poly meaning many or much. This can be a partial or complete additional digit or digits. It may affect the hands and or feet, and it may be unilateral or more common, which is more common, or bilateral. The condition usually involves just the phalangeal bones. Fifth finger duplications are the most common type. So these are people with 6 fingers, or if you can see on 778, the little blip on the 5th digit, a little extra, a little something extra right there. Okay, but you can see on that Wassels classification of the bifid thumb, how you can have a thumb bone with 2 little bones at the top. So we have to go and remove those. Okay, so this takes us into the breast procedures. Now we talked a little bit about breast procedures in the latter part of general surgery. Those were mainly like for breast cancer, and a lot of what we're about to talk about here is also for breast cancer, but also just for cosmetic reasons also. So on 781, in the red, it says, especially in Western society, this symbol of femininity, talking about the breasts, have less to do with the functionality of the breast than with its aesthetic qualities. And again, aesthetic, that's visually pleasing. Okay, so we want to have nice, perky, larger breasts. It, exudes youthfulness, vitality, sensualness, and so the breasts are hypersexualized in our Western culture, and so a lot of people want to get this procedure done, this augmentation done, to enhance. Now, sometimes they are too big, and so we have to go and decrease. But for this situation that we're about to talk about, the augmentation mammoplasty, this is to increase. So that's that first bullet under the anatomy. Augmentation mammoplasty is performed to increase the size of the breast or create a new breast post-mastectomy. Okay, so again, we can do these on cancer patients. But under the equipment in that third column, that first bullet, make sure that you have your fiber optic retractor set, because you are going to be going either above the muscle, above that chest muscle wall, or below the chest muscle wall. And so you'll need some sort of lighted system in there. Okay, under the practical considerations, the 2 types of implants available are saline and silicone gel filled. Saline filled implants are still used slightly more often than the silicone gel filled implants, and I'll tell you why. So saline is cheaper. A lot of people want saline because of the cost. However, the salines do not last as long as the silicone. And when the patient bends over, if they are like on hands and knees or they're just bent at the waist, if they have a saline implant and they kind of move or shake, you can see the ripple effect in the saline because it's just water, it's salt water in these implants. So you can see the implant kind of rippling like a wave, whereas a silicone implant, it's firmer, it's denser, it holds its shape, and so you do not see that. That is why they're more expensive. They are more natural looking than the saline ones. Okay. Continuing on to 782 at the top, that first bullet. Prior to surgery, the surgeon should collaborate with the patient in developing realistic, and I circled the word realistic, expectations regarding the size of the implant to be used, incision, and the planned outcomes. This is a big one because you'll have some women that will come in, or some people that will come in, and they want very, very abnormally large breasts. And as a plastic surgeon, you are a walking representation of his work. And so if you are disfigured and disproportionate, which we have seen on TV, then he will not do that to you. You have to go somewhere else. Someone that is a little less ethical. If you have a good plastic surgeon, he will pare you down. A lot of times women will just want bigger, like they're a size A cup and they want something bigger. That plastic surgeon may give them like a C cup or a D or a double D, because once the swelling goes down, they will sit and they will look more natural. And a double D they're not too big. A C to a double D. Okay. Plus, they don't want to be straining your back. So a lot of people will get reductions because of back strain. So if you get the breast implants too large, it will then start to have wear and tear on the back muscles. All right, next bullet. The procedure should not prevent a woman from breastfeeding, although it should be kept in mind that there was minimal breast tissue present originally, except in the case of mastectomy, in which all breast tissue is absent. Okay, so the mammary ducts are not touched during a breast implant. The implant is going beneath the milk ducts, the mammillary ducts. All right, it should be noted that breast implants may distort radiographic studies such as mammography, making accurate diagnosis of breast cancer more difficult. When you turn 40 and you start getting your breast exams, the not mammoplasty, the mammographies, mammograms, this is also a good time to see if the implant is leaking. If there is fluid or silicone coming out of the implant, it still is going to be encapsulated in that scar tissue pocket that's now created for the implant, but you'll be able to see a leak. But if you do have the silicone implants, it is a little bit more challenging to see, especially if that person has dense breast tissue, to see if there are any changes for breast cancer purposes. Okay, under the procedure number 6, the implant sizers are inserted into the pockets that were made and inflated with saline to determine the final size of implants. The circulator will elevate the OR bed to raise the patient into a sitting position to allow the surgeon to evaluate the appearance and identify adjustments that should be made to the implants and or pocket. So he's going to put the implants in, he's going to fill them up with saline. So they're flat. You roll the implant up, you put it in the pocket in the chest, either above or below the muscle. And then there's like a little tube. He's going to fill it with saline. Then they're going to put that patient into sitting position to see where the breasts hang, where they fall, and make sure that they're both equal in size and that they are not just disproportionate. Now, if they're silicone, he will do the same thing, but silicone, they come pre-filled. You cannot fill it with silicone. And so this is where it's a little bit more traumatic on the patient. You need those retractors because you're going to have to retract really hard to stuff those implants in there and then sit up. Depends on your plastic surgeon whether you get above or underneath the chest wall. If the patient is very, very tiny, or just not overweight, they're just regular, like, within a decent BMI, the surgeon may want to go underneath the muscle. Underneath the muscle, it gives a more natural look. So the breast tissue on top of the muscle, that is all the patient. That's all you. The implant is underneath. So when someone feels the breast tissue, that is all natural. The enlargement comes from the muscle being pressed up against into that breast tissue by that implant behind the muscle. These are more painful than the implant going above the muscle, right beneath the fatty tissue in the breast. And so when the breast tissue is manipulated on the outside, they are actually feeling breast tissue and the implant, okay? If that makes sense. We'll talk more about this in class. But you can see what's going on 783. There are multiple ways to put in breast implants. You can go underneath the nipple. You can go underneath the breast where the scar will be invisible. because of where the breast hangs. It will hide that. Some surgeons will go through the umbilicus, the navel, the belly button, and tunnel it through some areas. I don't know of any that do that here locally, though. Okay, so if there was breast cancer, the next a great way to create a breast is to do a tram flap. So let's be on 784. You can see there is a lot of reading under the anatomy. This is a big plastic surgery case. Okay, so you're going to be doing a transverse rectus abdominis musculocutaneous flap, or a tram flap. And so that first paragraph on the page, it says, this is breast removal due to cancer. We are doing tram flaps because of breast cancer. Okay, so there where you see the two bullets, these are the options to create a new breast. The first one is an implant reconstruction. So if they have enough tissue remaining from a mastectomy, they can put in a tissue expander and put in an implant and call it a day. If they are completely flat, like if you see on that next page, letter A, how there's nothing there, they may need to do a flap reconstruction. And that is when, if you see on B, they're going to take some of that rectus abdominis muscle and it's going to be attached to the pedicle, so they're not going to completely dissect it from the body. They're going to dissect it from the bottom, take it up, twist it, and create a breast with that. So under the flap reconstruction, let's look at number 1 and 2. So number 1, free flap reconstruction involves totally removing the tissue to be transferred from its original location and transplanting it to the chest. The blood vessels must be microscopically reconnected at the new site. So you are disconnecting both ends of this muscle and transposing it somewhere else. That is a free flap. You are freeing it from the body. You can take it out of the body and put it somewhere else. Pedicle flap reconstruction allows the tissue to be transferred to remain attached to its blood supply, and that's what a tram flap is. It's a pedicle flap. So you're only taking off one part of the muscle and flipping it over or moving it to the side where it's still attached to the blood vessels, if that makes sense. Okay, so at the bottom of number 2, the latissimus dorsi musculocutaneous flap and the tram flap techniques are the two most commonly used pedicle flaps. Okay, and again, you can see this on 785. Okay, so on 786, continuing, about halfway down that paragraph at the top, it says, often the general and plastic surgeons work together for the entire procedure, changing roles as primary surgeon and assistant as the case progresses. So you will have both surgeons in on this case. Okay, you can see the tunnel dissection being done on 787. We're not doing a big midline incision. We're going to be doing this endoscopically, a lot of times by feel. A lot of retractors are being used to look through that tunnel. Okay, so that takes us to 789, the nipple reconstruction. So under the equipment, you're going to need a dermatome because you're going to be shaving off some skin. A sterile tattoo equipment and needle. We cannot recreate a nipple and all that it can do. It responds to temperature, it responds to tactile stimulation. We cannot create that. So, or the color. And so we have to tattoo what it will look like. But we can create a synthetic nipple by using skin. Okay, so the practical also under the equipment, that last bullet, you're going to need 3 15 blades. You're going to be using a lot of 15 blades. Okay, so the practical consideration, nipple reconstruction may be performed at the time of breast reconstruction. However, some surgeons prefer to wait until the breast tissue from the reconstruction procedure has healed, swelling has disappeared, and reconstructed breasts are in normal anatomical position. and the procedure is usually performed 8 to 10 weeks post-reconstruction. This is optimal because if you try to create a nipple on a swollen breast that has not gotten into that anatomical position, once the swelling's gone down, the nipple may be in a different place or a little slightly off. So these are usually for cosmetic purposes. You do see some breast reconstructions that have no nipples, but if someone's really attached to that look or whatever, they may want, they need that normalcy, so we can create a nipple. Okay, so you can see how we do this on 790. We're going to just do a little kind of like a keyhole. We're going to create at the top that areolar graft. Okay. All right, with a lot of sutures. Now, when we do create that nipple, they will always look erect. So again, they don't respond to temperature like native nipples, okay? They don't go flat whenever it's hot. They will always have that little perkiness. All right, 791, mastopexy, the anchor technique. So mastopexy is performed to correct breast ptosis. The ptosis can be severe enough to cause lower back problems as well as cause the straps of brassieres to indent the skin, causing chronic discomfort. So basically, these are the deflated water balloon looking breasts. You can see at the bottom, they're sagging, they're irregular, and so we need a little lift, okay? And you can see on 792, the anchor shaped pieces, that's what happens. You're just going to pull that up, and then you're going to suture it at the bottom of the nipple, around the nipple, and then then you make sure they're even. Okay, that takes us to 793, our final area, the abdominal procedures. So the second sentence, the procedures should not be confused with paniculectomy. Okay, that is the removal of the apron of abdominal fat called the pannus in the formerly obese patient who lost a large amount of weight. The two commonly performed procedures are liposuction and abdominoplasty. Okay, so we're not doing a paniculectomy. That pannus that droops down below the pubic area, that big overhanging apron of fat, we're not doing that. I mean, we can, but what we're going to be talking about right now are the abdominoplasty. Okay. All right, so the first one is the suction lipectomy or liposuction. And under the anatomy, suction lipectomy is performed for the removal of subcutaneous fat deposits to provide the patient with a pleasing cosmetic appearance. Okay, there will be some bruising and some swelling, possibly some dimpling afterwards. So these are not 100% guaranteed to have the correct outcome that's wanted. Sometimes you will have a little bit of dimpling. All right, under the equipment, second column, last bullet, medications and solutions to mix tumescent solution. The tumescent solution is made up of saline, 0.5% lidocaine with epi, and Whiteace. And we're going to talk about this tumescent solution right now. So under the practical considerations on 794, all the way on the right-hand side, that last sentence, so the mixture liquefies the fat to make suctioning easier. And what they're talking about is tumescent. So you may want to draw a little line as you underline that last sentence and write tumescent, T-U-M-E-S-C-E-N-T. So that mixture liquefies the fat to make suctioning easier. So the Whiteace, the half width, and the saline to do your liposuction. Okay. And then that takes us to abdominoplasty on 795. So abdominoplasty is performed to thin the upper abdominal fat, tighten the abdominal muscles, and remove excess subcutaneous fat and skin from the mid to lower abdomen. Okay. All right, under the equipment on 796, you're going to need that fiber optic retractor set. And then under the practical considerations, a woman planning to bear children should delay undergoing this procedure until all pregnancies are complete for obvious reasons. Okay, you don't want to get all nice and fit and tight and then expand and gain your weight again. And then that last bullet, test the fiber optic retractors prior to the patient arriving in the OR. So you can see on 797 what we're doing. So there we got a little bulge on A. We're going to zip it up in B. We're going to, usually we're going to make it like a fan and steel or a low transverse incision. Okay. All right, and that wraps up the plastic surgery. We will talk more about some of these procedures in depth. Just please bring to class any muddy areas that you need clarification on, okay? I'll see you soon.